Hello guys, my name is Masuda Qasimi and today we are going to talk about surgical anatomy of mandibular nerve. For best knowing, we are going to start from trigeminal nerve. The fifth cranial nerve or the trigeminal nerve emerges from the site of the pons and has a large sensory root and a small motor root. The root crosses the apex of the petrous temporal bone beneath the superior petrosal sinus to enter the middle cranial fossa. Chief sensory nerve for the face and head has sensation of pain, temperature, and touch. Motor action on muscles of mastication. Branches of trigeminal nerve. There are three main branches: the ophthalmic branch, which is sensory nerve, and innervate lacrimal glands, conjunctiva, forehead, eyelids, anterior aspect of scalp, and the mucous membrane of the nose. The maxillary branch, which is also sensory nerve and innervate cheeks, upper gums, upper teeth, and lower eyelids. The mandibular branch is also sensory and motor, which innervate teeth and gums of the lower jaw, penis, lower lip, and tongue, muscle of mastication. Mandibular nerve is the largest of three divisions of trigeminal nerve, also known as nervus mandibularis, inferior maxillary nerve. It also both sensory and motor fibers and supplies the teeth and gums of the mandible, the skin of the temporal region, the auricula, the lower lip, the lower part of the face, and the muscle of mastication. It also supplies the mucous membrane of the anterior two-thirds of the tongue. It's the nerve of the first brachial arc and supplies all structures derived from the mandibular or first brachial arc. Course and relations of the mandibular nerve. Mandibular nerve begins in the medial cranial fossa through a large sensory root and a small motor root. The sensory root arises from the lateral part of the trigeminal ganglion and leaves the cranial cavity through foramen ovale. The motor lies deep to the trigeminal ganglion and to the sensory root. It also passes through the foramen ovale to join the sensory roots just below the foramen, thus forming the main trunk which passes through the infratemporal fossa. After a short course, the main trunk divides into a small anterior trunk and a large posterior trunk, as you see in here. Branches of the mandibular nerve. There are two main branches, meningeal branch and nerve the medial pterygoid. Meningeal branch, as you saw here, also known as the nervus spinuosus, it enters the skull through foramen spinuosum with the medial meningeal artery. It supplies dura mater of the medial cranial fossa. The next one is nerve to medial pterygoid. It arises close to the aortic ganglion and supplies the medial pterygoid from its deep surface. This nerve gives a motor route to the aortic ganglion, which does not relay. It supplies the tensor veli platini and the tensor tympani muscles. From the anterior trunk, there are buccal nerve, gastric nerve, deep temporal nerves, nerve to lateral pterygoid. Now we are going to talk about buccal nerve. It's the only sensory branch of the anterior division of the mandibular nerve. It passes between the two heads of the lateral pterygoid, runs downward and forwards, and supplies the skin and mucous membrane. Related to the buccinator muscles. It also supplies the labial aspect of gums of molar and premolar teeth. Gastric nerve. Gastric nerve emerges at the upper border of the lateral pterygoid just in front of the temporomandibular joint, passes laterally through the mandibular notch and company with the gastric vessels and enters the deep surface of the gastric. It also supplies to the temporomandibular joint. Deep temporal nerve, as you're seeing here. Deep temporal nerves are two in number, the anterior and posterior nerves. They passes between the skull and the lateral pterygoid and enters the deep surface of the temporalis. The anterior nerve is often a branch of the buccal nerve, and a posterior nerve may arise in common with the gastric nerve. Nerve to the lateral pterygoid. Nerve to the lateral pterygoid enters deep surface of the muscle. It may be an independent branch or may arise in common with the buccal nerve. There are branches of the posterior trunk: auriculotemporal nerve, lingual nerve, inferior alveolar nerve. We're going to start by auriculotemporal nerve. Auriculotemporal nerve arises by two roots which run backwards, encircle the medial meningeal artery, and unite to form a single trunk. The nerve continues backward between the nape of the mandible and the sapheno-mandibular ligament above the maxillary artery. Behind the nape of the mandible, it turns upward and ascends on the temple behind the superficial temporal vein. Next nerve is lingual nerve. Lingual nerve is one of the terminal branches of the posterior division of the mandibular nerve. It's necessary to the anterior second third of the tongue and to the floor of the mouth. Course and relation of the lingual nerve. It begins 1 centimeter below the skull, runs between the lateral and the medial pterygoids, and about 2 centimeters below the skull is joined by the chorda tympani nerve. Emerging at the lower border of the lateral pterygoid, the nerve runs downwards and forwards between the ramus of the mandible and the medial pterygoid. Next, it lies in direct contact with the mandible, medial to the third molar between the origins of the superior constrictor and the myloid muscles. It leaves the gums, runs over the hyoglossus deep to the mylohyoid and around the submandibular duct, dividing into terminal branches. Inferior alveolar nerve. Inferior alveolar nerve is the largest terminal branch of the posterior division of the mandibular nerve. It runs vertically downward laterally to the medial pterygoid and to the sapheno-mandibular ligament. It enters the mandibular foramen and runs in the mandibular canal, accompanied by the inferior alveolar artery. Branches of the inferior alveolar nerve. The mylohyoid branch contains all motor fibers of the posterior division. It arises just before the inferior alveolar nerve enters the mandibular foramen, pierces the sapheno-mandibular ligament with the mylohyoid artery, and supplies the mylohyoid muscle and the anterior belly of the gastric. While running in the mandibular canal, the inferior alveolar nerve gives branch supplying the lower teeth and gums. The mental nerve emerges at the mental foramen and supplies the skin of the chin, skin, and the mucous membrane of the lower lip. Its incisive branch supplies the labial aspects of gums of canine and incisor teeth, as you're seeing in the picture. By passing the age, the shape of mandible is also changing. It's the shape of mandible at birth, in childhood, adult mandible, and geriatric mandible. We have some complication in mandible, such as dislocation, which it's happen in temporomandibular joint. Its normally closed position jawbone is separate from skull by a soft disc that acts as a occlusion when you chew, speak, or swallow. Temporomandibular joint normal open position disc stay in place when jaw is in use. Abnormally disc is pulled forward when jaw is in use, causing the bone structure to grind together. Here's the reduction that the procedure is doing by downward pressure followed by posterior and upward movement. Fracture. First, mandibular angle fractures accounts for 23% to 42% of all facial fractures. The most common causes of a mandibular angle fracture are motor vehicle accident and assaults or violence. Second, there are two main proposed reasons why the angles of the mandibular is commonly associated with fractures. The first reason is the presence of a thinner cross-sectional area relative to the neighboring segments of the mandible. Second is the presence of third molars, particularly those that they are impacted, which weakens the region. Upper and lower border wearing osteosynthesis, a non-ridged technique that should be supplemented with intramaxillary fixation. Masticatory muscles produce tension at upper border and compression at lower border. Thus, under most functional situations, fractures of the angle tend to open at the superior borders. Surgical consideration in mandibular canal, partially or completely dentalus cases, placement of implants difficult, injury to the mental nerve, peristalsis to the skin of the chin, the lower lip and the labial mucosa, injury to the lingual nerve during flap reflection, releasing incision anesthetic injections. External oblique ridge, resective surgery difficult because of the amount of bone to be removed. Apical positioning of the flap is difficult in these areas. A high buccinator attachment results in a shallow vestibule, making grafting producer difficult. Mandibular tori, the mucosa over the tori region is usually thin and hence is subject to tearing. Source of autogenous bone for grafting procedures. Myelohylate ridge, a permanent ridge may. Bony ledge resulting in limited surgical access and also makes flap reflection difficult. Chronoid process ridge, a permanent chronoid process may be in close proximity to the maxillary tuberosity, resulting in limited surgical access. Genial tubercle ridge. In case of severe horizontal bone loss, they may pose a problem during implant placement and flap reflection. Alveolar process ridge. Permanent teeth results in marginal tissue recession, bony descents of fenestration. At the conclusion, we can say that the selection of an appropriate surgical technique that can best satisfy the treatment goals and objectives is directly influenced by thought knowledge of anatomic relations between bone, soft tissue, and teeth. The study of anatomy of mandible and surrounding structure is essential. Here you can see the reference that I use for making this presentation, and there is the YouTube links about surgical anatomy of mandibular nerve. Thank you for your attention.